So, good morning, everybody. Good morning, everybody. Medical science is a rapidly advancing field where yesterday's fact may become matter for the archives to store, and today's fact may not find agreement with experts of tomorrow. So, continuing medical education is therefore an integral part of medical profession. We have arranged this webinar on cardiometabolic update, and I'm sure this will contribute immensely towards better patient care. Our opening batsman is Dr. Neeta Deshpandey, and I request Dr. Jindal to introduce her. Please show the CV slide.
So I know
The
Dr.
slide will
Neeta.
be, Dr. Jindal's slide will be on the screen.
Okay, sir. So I know Dr. Neeta for very long. We have been sharing stage. Audible? Yes, Dr. Neeta Deshpandey is a diabetologist and bariatric physician in Belgaum Diabetes Center Care for Institute of Diabetes, Obesity and Metabolic Health. She is medical director, Centra Care Super Specialty Hospital and MRC, principal investigator for several global clinical trials, several publications in peer-reviewed journals and also textbook chapters. Received several orations like RSSDI oration 2016, Vandana Bale oration national AIAA RO 2019 and RSDI GP Moses oration in 2021. Our topic for today is very exciting. We know that so many new drugs have come for treatment of obesity and
So you've gone on mute, sir, Dr. Jindal.
Okay, so sorry for that. So Dr. Deshpandey is a diabetologist and bariatric surgeon, and she is working in Belgaum, Karnataka. She is a well-known figure amongst the diabetologists and endocrinologists. She is a speaker in most of the conferences related to diabetes and metabolism. And today's topic is very, very exciting. Newer drugs which are coming in and for treatment of obesity, and they are not only drugs for obesity, they are also very good drugs for treatment of type 2 diabetes, almost mandated in certain categories of type 2 diabetes. Along with that, we know that now they are also recommended for reducing the progression of CKD, for reducing heart failure, reducing the MACE. So over to Dr. Deshpandey for our delivery.
Thank you, Dr. Jindal, for a warm introduction. And at the outset, I would like to thank the Cardiometabolic Update team and Dr. P C Manoria in particular for giving me an opportunity to be here today to speak about this topic in amongst this august audience. So the thing is that everyone knows, before I share my slides, a short preamble would be that all of us are very, very aware that the newer anti-diabetic, anti-obesity medications are excellent in terms of weight loss. I'm going to show you how how they bridge the gap between lifestyle modification and maybe an extreme thing like a bariatric surgery. All of that is known, but today my topic is very different, and that is about what do these drugs do beyond just weight loss. So let me start by sharing my slides. All right. So as I said, what are the benefits of these drugs beyond weight loss? We know that they are weight loss drugs, so they do cause weight loss, but beyond that, do they have any other benefits? Are there any pleiotropic effects of the same? And that is what I am going to actually explore in my 15 to 20 minutes talk today. So if you look at this, you can achieve about 5 to 10% of weight loss with the help of diet and exercise. Of course, there are outliers. Younger people may lose even more, but I'm talking an average. Average is around 5 to 10%. And if you look at bariatric surgery, then it is 25, 30, 35, 40%. So all of these things are there. But there is a gap in between, and that's where a lot of obese patients lie. A huge chunk of obese patients lie between these two extremes, and that is where the pharmacotherapeutic agents can actually be very, very useful in terms of bridging the gap between just lifestyle modification or bariatric surgery, as you can see here. So the treatment gap is actually made good with the help of pharmacotherapeutic agents, as we all know today. So, what really is the definition of a second generation newer anti obesity medication? So, basically, it should have the ability to safely produce an average of more than 10% placebo subtracted weight loss in RCTs. And in the majority of patients, and an ability to safely produce a greater than 15% weight loss in more than 50% of patients as an adjunct to lifestyle. So that is basically the definition of a new generation anti-obesity medication. Now I am only going to focus on the pleiotropic effects. I'm not going to show you any weight loss data. That is all out there. Everyone knows about it. But I'm going to talk about what these drugs do beyond just weight loss. Now, this is the step one trial with semaglutide injectable 2.4 milligrams once weekly. And what you can see here very, very nicely is that there is a change in body composition as well towards a better body composition when you use these anti obesity medications. As you can see on the right hand side, you will see that the total fat mass decrease is with semaglutide is minus 3.5, whereas it is only minus 1.4 with placebo. And when you look on the right hand side, when you look at the lean body mass, you have a corresponding increase in lean body mass by 3%, whereas there is absolutely nothing with placebo. So that is an important thing for us because all of us are very, very worried about sarcopenia that happens with weight loss. There is sarcopenia in obesity as it is, and if one starts to lose weight more and more, you are worried about more and more sarcopenia. You want to preserve muscle and make sure that the majority of the weight that is lost is in terms of fat. And that is what this study is showing to you. Same thing in step 6, again with the same molecule, you can see that there is a change in abdominal visceral fat area, very well seen. VFA, what we call. So there is a change in abdominal VFA, as you can very well see, with semaglutide 2.4 or 1.7, both much higher than with placebo. So you can see that the visceral fat, which is the toxic, metabolically bad fat, that is reducing so nicely with the help when you use semaglutide even at a lower dose. So 2.4 is supposed to be the highest dose for obesity, but you can see here very well that visceral fat area is also reduced. So this is an added advantage of the newer anti-obesity medications that you are seeing. Now let us look at what improvement you can have beyond this weight loss, beyond the fat loss. And you can very well see here, again with the same molecule. I'm using this molecule as a prototype of the newer anti-obesity medications, not particularly semaglutide, because most of them act in the same way. So you can see here that you have a reduction in systolic blood pressure, diastolic blood pressure, importantly, C reactive protein, which is an inflammatory marker, which you definitely want should reduce in obese individuals, because all of us know that inflammation is at a high level in obese individuals, and you want that this should come down. C reactive protein is a marker of inflammation, and that has been shown to come down with GLP-1 receptor agonist therapy like semaglutide. The fourth thing that you can see, the last column that you can see, is triglycerides. We all know that obese individuals have hypertriglyceridemia, fatty liver, etc. And you can see that in this trial, they have shown that triglyceride also comes down by 19 points. So this is very important for us. So these are all cardiovascular and metabolic risk factors that have all been shown to come down very, very nicely when you use these newer anti-obesity medications. This is a very interesting slide which I want you to look at, presented in 2024. And this talks to you about the mechanical complication of obesity. So, all the cardiovascular, metabolic things we have talked about, but we also should remember that mechanical issues, mechanical problems are a large part of the comorbidities of obesity. And knee osteoarthritis is the most important among them. So you can see that the pain score reduces. There are studies which are trying to show that these effects are quite independent of the weight loss. We all know that when weight loss reduces, the burden on the knees is reduced, so the knee pain comes down. But there are studies which are trying to show that there could be metabolic changes that happen in the joints with these drugs, which could by themselves independently reduce pain. And that is what this study is showing to you, that there's a pain score called the WOMAC pain score, and you can see that as compared to placebo, which is in green, you can see that with the use of semaglutide, it comes down by several points. So knee osteoarthritis. So this is for the pain score. What about the physical function? So obviously, when pain comes down, the physical function may improve, but again, there could be an independent effect as well. And you can see that in patients with knee osteoarthritis, the physical function score also is better in the patients that use the drug as compared to placebo. So that is another thing which is a pleiotropic effect, or you can say an effect beyond weight loss. Then came all of us know about semaglutide, we know about liraglutide, we know about it. These are all single receptor drugs. That means they act only at one receptor. Then came the discovery of multi-receptor drugs. There was the discovery of dual and triple agonists. Now we already have one dual agonist that has been already come that has already come into the Indian market, and that is tirzepatide. And there are triple agonists where studies are underway, like retatrutide, where you get huge weight losses, and they have unprecedented efficacy, at least in terms of weight loss. In fact, the benefits of these are approaching those of gastric bypass with retatrutide, which is the triple agonist that has got around 26% weight loss. That means a 100 kg man coming down to 75 kg with just this drug. The studies are underway, phase 2, phase 3 trials are underway. It came in NEJM last year, and the results are there. So you have these drugs that are causing immense weight loss, but today we are discussing what they do beyond causing this immense weight loss. So this is what you're getting, controlling obesity with multi-receptor drugs. So you can see here with monoagonists, you had very good results like semaglutide that I have shown you already. Look at the darker pink line with dual agonists. It's going beyond 20% weight loss. And now we're talking about triple agonists, and you see that that line is almost abutting that of bariatric surgery, which tells you that we have come a long way with anti-obesity medications, almost coming close to the bariatric surgery results that you can see. So what are the benefits of GLP-1 drugs for obesity? So you can see weight loss right at the top there. But what you see elsewhere, these are all the pleiotropic effects beyond weight loss. So I'm going to show you some things about that as well. So heart health protection, lower cholesterol, lower blood sugar, less inflammation, sleep apnea relief, kidney health protection, less visceral fat, reduced appetite, lower blood pressure. So I already showed you blood pressure data. I already showed you some anti-inflammatory data. And I also showed you dyslipidemia, lower triglycerides. So you can see that there are so many benefits that go beyond weight loss for these particular drugs. So, anti obesity drugs and their effect on obesity complications, or let's say comorbidities, they are based on randomized clinical trials. There are CVOT trials as well. And you can see here that today you have a choice. So, supposing, like for example, you have a patient with obesity who has food craving, you can use liraglutide, semaglutide, tirzepatide for food craving to come down. We don't yet have naltrexone, bupropion over here. But then there are other things like obstructive sleep apnea. We have data with liraglutide. Type 2 diabetes, all of them can reduce the blood sugar. Cardiovascular disease, I've already shown you some data with liraglutide, but there is some with sema, terzepatide, all of these. NAFLD, we have data now with almost all the GLP-1 receptor agonists and dual ones, all the modern ones. And you can see that I showed you data now already for osteoarthritis. And Alzheimer's disease is being actively studied for this, and Parkinson's disease as well. Semaglutide studies are underway. So you can see here that so many other diseases can be impacted in a beneficial way with the help of these newer anti-obesity medications. There are trials which have borne out these kind of results in this particular scenario. So these are the various studies. You can look them up and you can see that depression, type 2 diabetes, NAFLD, obstructive sleep apnea, all of these with tirzepatide, semaglutide, you can see these are all the studies that have been done. You can go through these studies and see what a wealth of information you will get from that, knowing what these drugs can do way beyond the weight loss effect. So there are plenty of more studies underway, and these are just some that I have quoted here for benefits on all the other comorbidities that obesity entails. So let us go one by one and just see briefly what these are doing. So as far as heart health is concerned, I urge you to go and look at the SELECT study, which found semaglutide consistently reduced major CV events by about 20% among patients with prior CV disease and overweight or obesity. And the drop was observed for CV-related death, non-fatal MI, and non-fatal stroke. Then came the STEP heart failure with preserved ejection fraction. And this also found multiple improvements among patients with obesity related HFpEF. And in addition, GLP-1 mechanisms appear to have direct effect on blood vessels, blood pressure that I've already shown to you, lipids I've already shown to you, which can further influence CV related risks and events. So heart health and heart protection is a definite benefit with the help of these newer anti-obesity medications. What about renal health now? So the FLOW trial, the latest one, found semaglutide prevented major kidney disease, CV events, and death in patients with chronic kidney disease and type 2 diabetes. So this is again very important data for us to show that it has got pleiotropic effects. In particular, patients who took semaglutide had a 24% lower risk for a major kidney event, such as kidney failure onset, dialysis, transplantation, as well as death from kidney or CV related causes. And the risk for death from any cause was also 20% lower. So, this is huge data and very, very important data, because you know that obesity comes with all these other comorbidities and you have to have organ protection. So, this was about renal health. Then comes hepatic health. All of us talk so much today about MAFLD, and we know that it can lead to cirrhosis and all of that. And in a September analysis published in JAMA, GLP-1 was associated with a statistically significant reduction in risk for progression to cirrhosis among patients with metabolic dysfunction, that is MASLD, or fatty liver disease. And there are other studies also which have shown reduced risk for hepatocellular carcinoma, liver transplant, and liver related death as well. So these are all being explored. A lot of data has been published with various organs being protected, being shown to be protected by these newer anti-obesity medications. What about bone health? Because when we talk about sarcopenia, we also worry about bone health. So the STEP 9 trial found semaglutide improved knee pain and physical function. I have already shown you the slides and the data for this in people with knee osteoarthritis. And although weight loss certainly reduces it, researchers are investigating whether these drugs act specifically on joints through metabolic changes. Mental health, extremely important. all obese patients are have some mental issues or the other. So there has been a decline in addictive behavior such as drinking, smoking, etc., and lower risk for suicidal thoughts. Based on functional MRI studies, there is activation of brain reward centers which can reduce addictive behaviors. While the weight loss associated with GLP-1 may improve body image and overall mental health, there could be other things at play as well. Overall, full body health, if you had to look at, additional GLP-1 associations have come out for sleep health, Alzheimer's disease, the SURMOUNT OSA trial, reduction in, that is with tirzepatide, obstructive sleep apnea, improved sleep-related outcomes. Then, based on select trial data, I showed you about reduction in C-reactive protein, even in patients who didn't lose much weight. So even when the weight loss is not too much, there are still benefits of using this drug. It brings down the inflammation. And now we have trials that are recruiting patients that are looking at the effects of sema and tirzepatide on breast cancer risk factors, psoriatic arthritis, and polycystic ovarian syndrome. So it covers almost all the organs in the body. So to conclude, second generation AOMs achieve more than 10 to 15% weight loss in most patients safely. They improve the body composition. They significantly reduce visceral fat. There are cardiovascular benefits, renal protection, and reduction in kidney related mortality, and liver benefits, where the muscle progression is slowed down, reduced cancer risk, joint and bone benefits. I've already shown you the slides. Mental health impact is considerable, and there is decreased inflammation, improved sleep, etc. So AOMs redefine obesity therapy, offering multi-system disease modifying benefits and benefits way beyond the just the weight loss. So thank you all very much for a patient hearing.
Yeah. Thank you, madam. It was a very comprehensive talk.
Thank you.
So my take is, what is your take on oral semaglutide?
Yes, so oral semaglutide we know is licensed for use only for type 2 diabetes. It reduces weight otherwise also, but the license is for type 2 diabetes. So not many of these trials have been done on oral semaglutide. Most of these, whatever I have shown you, all the data is on injectable GLP-1 receptor agonists, not on oral. So, but you can always actually extrapolate, but the data is not there right now, at least for oral. All the data that I've shown you for all the pleiotropic effects is on injectable.
Yeah, recently the SOUL study suggests, which was mainly concerned for the cardiovascular SOUL study.
Yeah.
So that, yeah, Lokarai, yes.
Sir, madam, that was a wonderful talk.
Thank you.
A very good review of the subject. My question is regarding the weight rebound when you stop GLP-1 or GLP-1 plus. Comment on the weight rebound.
Absolutely, sir. But the question is whether you're viewing obesity as a disease or not. If you view it like diabetes, once the blood sugars come to normal, do we stop therapy? We don't. We may de escalate, but we may not stop it. So, extrapolating that, yes, there can be a rebound. There are studies also which show that if you stop it, it will rebound. There are certain weaning protocols that are being developed. When the weaning protocols are there, I'm sure a huge part of it will be reduction in sarcopenia. There will be protein intake. There will be increased exercise, increased resistance training. But it is very likely that there could be a relapse when you might have to use it again, just like in diabetes. When the blood sugars go very high, you give insulin, then you stop insulin, then you give only orals. So in that way, this disease will have to be approached in a very different manner. There may be some who relapse so fast that you may have to keep a small maintenance dose for a long period of time, maybe 1 year, maybe 2 years, 3 years. So it has to be viewed in that way, like a chronic disease where you may have to give long-term therapy.
Deshpande, it seems we are amidst an era of cardiometabolic revolution. But what pains me is the obesity paradox. So, what are your comments on obesity paradox and the data which is available? On
You're
one we
talking
see
about
decreased
weight loss actually causing increased mortality?
Now, weight loss improving mortality. There's data of obesity paradox, particularly in heart failure patient. The survival in heart failure patient with obesity is longer than those who are not obese.
That is true. But I would say that these are more of outliers because the date. I agree with you that the obesity paradox is there, and once a person develops heart failure, it's not a very good idea to go for aggressive obesity management. But before anything develops, it is a very good idea to reduce weight because you have benefits in plenty of ways. But what you say is right that once a person does develop cardiac disease or heart failure, it is not a good idea to do aggressive weight loss in these individuals. That's where I feel the obesity paradox is more applicable. Trying to do weight loss in patients who have already developed this kind of a problem.
There is a
Role
phase
of
2
these
trial.
in patients without obesity, without heart failure, without heart disease, and without diabetes. Just for
Role of
obesity.
these drugs, yeah. So role of these drugs, there are studies that are now underway. I did not show you that data that even with a body mass index that is as low as 27 or 26. So there is data that these drugs are useful, especially when it comes to type 2 diabetes.
I'm
We do
saying
not use these drugs
patients who are not
as
diabetic.
yet.
Patients
Yeah,
not diabetic.
we don't have data yet to show the use of these anti-obesity drugs in patients who are lean. So we don't have that yet. There is no data.
Not lean. So patients who are not diabetic and who don't have cardiovascular disease. Only obesity. Just for obesity.
Yeah, so these are anti-obesity drugs only. So they are meant to be used for that, and they will definitely reduce their risks for other diseases like heart disease, etc. Is what has been shown because you will have reduction in blood pressure, you will have reduction in triglycerides. So a seemingly simple obesity does have these minor comorbidities: a slight higher blood pressure, slight higher triglyceride, higher C-reactive protein. All these will come down. These will always be there, even in a case of simple obesity. Even fatty liver, for that matter.
Okay.
The other
My
issue is
question is,
okay.
yeah.
The other issue is the response is not homogeneous. So, are there any predictors of a good response and an inappropriate response with AOM, weight loss, and
Yes.
other benefits?
Yes, so that's a very valid point. So, people of certain ethnicities, people who are aging, and people who have diabetes are the people who show less than optimal weight loss. So, all the anti-obesity medications have shown that there is a much lesser quantum of weight loss if there is diabetes as compared to there is no diabetes. There is a definite difference, and these are also, we can call them predictors. But having said that, it is not always easy to predict who will lose weight and who won't. So the usual dictum is, if at least 5% of weight has not been lost in after 3 months of therapy, you have to treat them as non-responders and stop the therapy. So that is the dictum that is followed even in the clinical trials, and which should be followed even outside of clinical trials. So minimum 5% weight loss has to be there. Then only you can call it that the person is a responder. And these are
So,
some
good
of the
morning. One question which I have. One question is on sarcopenia. Actually, if you give these drugs, if you lose 10 kilos of weight, about 2 kilos, 20% is because of muscle loss. So how can you manage that?
Yeah.
I think that's an important question.
Yes. So thank you for that question. I did show some data on DEXA where it was shown that there's a preferential loss of fat in patients who are using this drug. So any weight loss, whether you do only lifestyle modification or any other weight loss, always there is going to be some muscle loss. It can't be zero muscle loss. But your task is to minimize muscle loss and maximize fat loss. And that is what these drugs otherwise also do. But second thing that one has to be very careful is that while patients are on this drug or any weight loss therapy, from day one, weight training and adequate protein has to be initiated. Otherwise, you run the risk of getting a lot of muscle loss. So lifestyle modification does go alongside this. So the diet and exercise has to be very, very specific when one is embarking on a weight loss journey in any case, but especially so with anti-obesity medications.
Neeta,
Dr.
are there
Deshpandey,
any drugs which can prevent sarcopenia in these patients?
We cannot prevent, but we can minimize.
Dr. Deshpandey, there was a phase 2 trial with monoclonal antibody bimagrumab to increase muscle mass. So your reactions on that
That's what I
for the
was
future?
talking.
I'm not really aware of that.
So there are some questions in the chat box. What is the status of anti-obesity vaccine in India, Dr. Deshpandey?
I have not read of it at all.
Another question is, any study comparing SEMA with TISA as anti-obesity
Right.
medication in non-diabetic?
Yes, there in non-diabetics. Yes, there are studies. There are studies, and it has shown that tirzepatide there is a whole lot of studies which and there are some of them have been compared. So the tirzepatide people have done that, and yes, tirzepatide has come out with higher weight loss. That data is out in the open.
Yes, Dr. Bill, please. Yes, you want to ask something? Yes, please.
Madam, my question is anti-obesity drugs except GLP-1 and their combination approved by DCGI in India. US FDA have approved many drugs, phentermine, topramide, orlistat, naltrexone and bupivacaine. So, which is the drugs except GLP-1, GIP and glucagon and 2 to 3 drugs combination? Is it approved in India by DCGI?
Non-incretin, if you ask, it's only orlistat. Only orlistat, nothing else.
Others like phentermine, topramine,
No.
bupropion, and naltrexone.
No.
That is approved in the US FDA.
Yeah, we don't have it here. Not approved.
Okay.
Another question in the chat box is, what is the incidence of thyroid medullary carcinoma in patients on anti-obesity drugs?
Yes. So what we know today is that any such incidence is not greater than placebo, and whatever we have data for increased MTC is in animal studies. So that is the data we have as of today.
Last
What about
question is,
retinopathy and anterior ischemic neuropathy, optic neuritis with the GLP-1 receptor agonist?
Yeah, they have talked about retinopathy also.
Ischemic retinopathy.
yes. So the last question is, are there any drugs which are preferentially better in adolescent obesities? Or it does not matter whether you're adolescent or
No, it does
otherwise?
not really matter. Only the labeling matters. Which one is allowed and which one is not. But otherwise, it does not matter. You can extrapolate the same data.
Thank you, Dr. Deshpandey, for a very mesmerizing talk, and there's lots of praise from the audience for your wonderful lecture. So